Well, welcome to everybody who's joined the webinar today. The topic of the webinar is understanding the relationship between social determinants of health and clinician burnout. This webinar is brought to you by the New Zealand Healthcare Home Collaborative, and the purpose of it really is to drive some discussion and some debate and look at some evidence around the important issue of social determinants of health and how we address those in the primary care environment, whilst also acknowledging the risks around clinician burnout. More specifically today, we're going to look at understanding the current challenges in primary care and professional burnout. We'll also look at the framework for a high-performing primary care, and its relationship to the quadruple aim, which will be an extension of the triple aim that many of us are familiar with. Thirdly, we'll look at potential opportunities to achieve this fourth area of the quadruple aim, and also look at some novel approaches to team-based care and how we can address social determinants of health using that approach. So we've got two great speakers today who are really have got a lot of experience and are certainly dedicated to this area of work. Our first speaker is Wanda Olaiwala. She comes to us from the US and she's currently CEO at Inspire Health Solutions. She also practices as a family physician. She's had many and varied roles in the health sector, including health system transformation and redesign. She's got particular expertise that include health system reform, health IT, and she's contributed enormously to the rollout of the patient-centered medical home approach in the US and across other countries. I notice Wanda is an avid tweeter, and she likes to tweet about women, healthcare, technology, equity, and books that she's written. Our second speaker that we've got today is Dr. Andrew Miller. So Andrew has been practicing for over 25 years now as a GP. He's practicing at the moment in Northland at Bush Road Medical Centre. Andrew's the clinical lead for the Healthcare Home Collaborative, and he's championed the approach of Healthcare Home over the last several years in New Zealand. He's also on the board of Manaia PHO, and he's been the chair there for about the last 8 years. So we're really, really thankful to have these two speakers today who can share their expertise. There'll be some polling throughout the webinar, and this is our chance to hear from you in terms of your views on some important questions that we'll put to you. And also, if you want to ask questions throughout the webinar, you can do so by clicking on the little Q&A button at the bottom of your screen. So to get underway, we are going to start with a poll actually, and just before Wando starts as our first speaker. So our first poll, which with a bit of luck will pop up on your screen any moment now, it's going to ask you, in your role as a clinician, to what extent have you experienced burnout as a result of addressing social needs within your enrolled population? And I can see on one of my screens here that that's popped up. So you can click in a tab there, extremely high, moderate, low, or not at all. So that's in your role as a clinician, to what extent have you experienced burnout as a result of addressing social needs within your enrolled population? So you have a minute or so to do that, and now I'd like to say hello, Wando, and welcome to New Zealand, so to speak, I guess. I'm not sure who's in our audience, but I think there'll be a lot of New Zealanders there, and we're really grateful to have you here today. So I'm going to stop sharing my screen now, and I'll hand over to you.
Excellent. Thank you so much, Nikki, for the introduction, and thank you to everybody for the opportunity to speak with you all today. I'm very, very excited to co-present with Dr. Miller and appreciate all of your attention. So I'm looking forward to seeing what some of those answers were in that poll. But as was said, my name is Dr. Wando Olaiwala, and I'm going to be speaking to you largely around what some of my research and my colleagues' research has been on, looking at the impact and the relationship of social determinants of health and burnout of physicians in the United States. So I wanted to give a little bit of brief context that will just level set us on some of the challenges that we're facing here in the United States. I'm here in the state of California, but a lot of this work has been done across the United States. The first thing I want to share, and this is probably not unfamiliar to people, which is the Commonwealth Fund, annually does these rankings of many of the large healthcare systems in developed nations and looks at how they perform and perform or outperform each other in relationship to care processes, access, efficiency, equity, and healthcare outcomes. And of the 12 that they look at, the United States tends to be one of the lowest. We usually rank as number 11 overall in terms of a number of these processes. So clearly there are a number of things, although we have a tremendously innovative healthcare system, we continue to struggle with meeting some of the international standards that others are meeting. So I want to make sure that's really apparent to you all. So I thought I would share a little bit of a story about a patient that I take care of in my clinic at San Francisco General Hospital, who came to me as a 46-year-old undocumented Mexican man who had a chronic seizure disorder and was on multiple seizure medications as I've been taking care of him. He is illiterate and he lives with his elderly patients who don't speak any English. He came to my office for a standard visit that we had for me to titrate his seizure medications because his levels were suboptimal. So when he came to that visit, he talked to me about the fact that he and his parents were recently evicted from their apartment. They were given 3 days notice to leave their apartment in San Francisco. And they were now squatting in a 2-bedroom apartment with his sister and her 4 kids. So the kind of things that jump out here, as I tell you that story, and if I were able to hear all of your actions, I would ask you, what are the things that kind of stood out to you here in this story? So, clearly there were a number of things that emerged that were challenges for this patient. Some of those things being the fact that he was living with his parents, that his parents did not speak English, that that they were evicted, and there was some question around the legality of that eviction, and also so many other issues that were related to the way he was going to receive his care. So what became really clear in that moment was that, I had goals for his visit. I wanted to manage his seizure medications, to check his levels and make sure that he was seizure free. But he wanted to get housing assistance and help me for me to help him find some long-term housing solutions, but also some more emergent housing solutions. And also let the clinic know that we shouldn't send his mail to his house because he was now displaced. You can continue with the slides. So, the story got worse. I found out that he was evicted because the landlord found someone that would pay more money. The eviction was actually not a legal conviction based on San Francisco law. I spoke to a housing worker to try to help him. And they said, well, for him to get a 2-bedroom apartment in San Francisco, he needs a minimum of $3,300 per month. That's US dollars. They were all unemployed. There was no income. And I said, okay, well, how can I get him on a waiting list so he can get the affordable housing options that we have in San Francisco? And they said, sure, you can put him on the wait list. That's totally fine. And the wait is a 5-year wait. And so, he was given a list of places that he could call, but remember, he's illiterate. He doesn't have a phone. And they told me that, I could not, even with a good doctor's note, I could not necessarily influence the housing options that he had. And continue, So I'm going to talk a little bit about some of what this story and this one encounter, but many other encounters like it, really magnified for me with some studies that we did while at the University of California, San Francisco. So we can go on. So we were really challenged by a number of significant gaps, including burnout in our physicians here. We know that primary care physicians like myself are at very high risk of burnout in the United States, and the rates of burnout for people like me, primary care physicians or GPs here, they're twice as high as other US working population and working professionals. And the burnout has a number of different effects on patients, the staff, and the systems. So we could just continue going. So when we look at how do you compare US physicians and all other US professional workers on all the different dimensions of burnout, including emotional exhaustion, depersonalization, dissatisfaction with work-life balance, we tend to do worse, and statistically significantly worse than other professionals in the United States. Continue. And then when you start to think about what that costs for us, so I've had an extensive amount of experience in physician leadership as a chief medical officer of a large network of clinics in the northeastern part of the United States. And it was always enormously expensive to replace a burnt out physician. We estimate it takes about $250,000 to recruit and replace a physician that's caring for a panel of patients. And that means that as that's happening, when people are burnt out, they're less able to care for their patients in an empathetic way, more likely to make errors, communication is impacted, the impact on colleagues and patients is impacted, and also personal challenges with depression and substance abuse. So the costs of burnout are not just financial, they're also significant on the system. We can continue. So there are personal costs, there are professional costs, there are systemic costs, and there are costs onto the patients and families that experience the care of a burnt out physician. Continue on. So this is, just a joke, you start to see people digress into and regress into very impersonal relationships with patients. That becomes a challenge. And this is just a cartoon to give a little bit of light humor in this moment, but you can continue on. So as we've been thinking about how do we actually empower the primary care provider, the people that are delivering care, the care team members that support them in the patient-centered medical home. And as was talked about earlier by Nikki, most people are very familiar with the triple aim, which is, how do we improve the experience of care for patients? How do we manage the health of populations? And how do we do it at a lower cost? And my colleague and the founder of the center where I was director, this Center for Excellence in Primary Care, Dr. Tom Bodenheimer, and our colleague Krasinski put out this article a few years ago looking at a transition from the triple aim phenomenon to the quadruple aim, recognizing that if we don't have a focus on that fourth aim, the provider experience, the experience of people that are actually taking care of patients, and we don't pay attention to that, we're going to continue to struggle, even if we have all the other three aims, and it's going to be hard to get them without it. So as you think about the quadruple aim, that fourth aim, I've been doing a lot of work in the area of how do you prevent burnout and how do you handle burnout when it starts to happen. This is a look at 10 steps to prevent physician burnout, which was published by Mark Linzer and his colleagues in Chicago in the Journal of General Internal Medicine a few years ago. And they outlined a number of different metrics and approaches that you could take. Some were really focused on the institution itself. Some are focused on the actual work conditions in which physicians practice and giving them some more control over those conditions in which they practice. Some are focused on career development, and some are focused on self-care. But if organizations and institutions could really apply some of these tactics, they could potentially prevent burnout or manage it if it occurred. So when you now add in this other dimension though, and particularly for primary care providers that are working with patients that have complex socio-behavioral, socio-environmental needs, it becomes a big challenge because not only do you have the regular burden of taking care of patients and providing patient care in a very culturally competent, linguistically competent, respectful way, but you also have the social needs that your patients have that might impact your ability to give good care. So what we were doing is thinking about what is this relationship between social determinants of health and primary care. And you can continue to click through. We know that there's that social determinants that for people that are practicing in what we call the safety net, which are our public hospitals, community health centers, places that serve patients regardless of their ability to pay, and often have patients who are socially challenged or on the lower socioeconomic scale. There are very few resources to address social determinants of health systematically in these clinical settings. Burnout is actually more pronounced with primary care providers working with more vulnerable populations because the resources are low and the material and emotional needs of their patients are very, very high. So there is this connection between social determinants of health and primary care. So when you think about patients who are vulnerable, and many patients, you can go ahead and click through, but the treatment for these patients is not just a pill. So in my case, giving this man a higher dose of his seizure medications or titrating his medication was not necessarily the treatment. The treatment was really more around language and literacy. How are we going to get him to understand this paper that they've given him with all these options that he cannot read? What kind of legal support can we provide? Housing, stable housing, financial support, things like food, transportation, clothing. The treatment actually becomes more than healthcare. And so there's no way to really divorce the social determinants of health from the delivery of primary care if you want to have success. So you can continue on. And as I think about my patient, JR. So we felt like there was not that much research that was examining this association between social determinants of health and the burnout factor for primary care physicians, but we postulated that there was a relationship. But there were no surveys that were dedicated to understanding the relationship, so we decided to build one, and you can continue on. And so what we did is we wanted to understand what is the relationship between how clinicians perceive their capacity to address social determinants of health and burnout among clinicians. Go ahead. So to do this, we designed a cross-sectional study, and you can go to click through, which was done, and there were kind of basic three things that I'll share here. One was that we did this as a web and paper-based survey in 2014, 2015. We surveyed approximately 500 clinicians throughout 3 different systems in the greater San Francisco County, including 10 county-based clinics, 6 university-based hospital primary care practices, and 3 Veterans Affairs related clinics in the San Francisco city and county. And you can continue on. And so we wanted to understand how do they feel about this? And so we built a conceptual model for clinician perceptions on capacity, looking at what is the knowledge that they have? Do social needs impact my patient's health? And we felt like that was important to understand their just baseline knowledge about that relationship. We also wanted to understand what was their attitude about that. Is it important for me in the primary care setting to screen for patients' social needs? We also wanted to understand their confidence level. Are they comfortable even screening? Some people are saying, I don't even want to ask because I'm not sure what to do if I do ask. We also wanted to know their skills. Do they have skills to address those needs? And then also organizational capacity. So there's a personal capacity and an organizational capacity to address social needs. You can continue. So in this model, we hypothesized, and you can continue on, Amarjit, that we would look at all those questions, and we built this scale that we asked this question to all of the providers. We published this in the Journal of Healthcare for the Poor and Underserved last year, or earlier this year rather. And so this is the question that we asked. This section is designed to understand your ability to address the social needs of your patients, and we listed some of what those social needs included. And we asked them if they were comfortable asking about social needs, if they felt it was as important to address those needs as it was their medical needs. Did they have the personal skills to address the social needs? And did their clinic have the resources, such as staff, programs, other tools to address their social needs? Simultaneously, we were asking a number of questions on this survey using the Maslick Burnout Inventory, the MBI, that looked at professional efficacy, emotional exhaustion, and cynicism. And then you can continue, but we were looking at the relationship between these two things. So in our univariate analysis, we found that each of those 4 social determinant of health questions was significantly associated with lower levels of exhaustion, cynicism, and professional efficacy. So that meant that if you felt that you had high capacity to address your patient's social needs, then you were less likely to report being exhausted and cynical, and you're more likely to have a high level of professional efficacy. And then in a multivariate analysis where we looked at multiple factors and tried to separate these out and see, in the model, which ones remained a significant predictor of burnout, we found that the primary care providers' perception of their organization, their clinic's capacity, and their resource to address the social determinants was the only one that remained a significant predictor. So you can continue on. So that was huge for us to find out that if we actually have the organizations equipped to provide resources and support, we could potentially lower burnout in all 3 of those measures. So we found that even if the beliefs of the physicians did not necessarily matter, people that had more direct patient care, so more hours of patient care, had a stronger association between their clinic capacity and burnout. But regardless, it became so important that what people felt about the way their organizations could handle and gave them tools to address social determinants for their patients was a great predictor of their burnout. So as we started to think about how does this fit into that larger 10 steps or whatever number of steps to address burnout, and going back to that 10 steps graphic that I showed you, there were a number of different things that have been proposed as strategies to get us to that quadruple aim, to improve that provider experience. And some of those things have been, improving the culture of the team, the working conditions, institutional metrics, decreasing the stresses that have been created by electronic health records, career development and self-care. And we've now offered this additional strategy, which is really optimizing the resources in that setting to be able to address patients' social needs. And that's where we felt like the next frontier of really looking at burnout and the quadruple aim and the experience of clinicians became very important. We'll continue on. So back to my patient, because I'm sure you wanted to know what happened with JR. He left that visit. We didn't end up doing the labs, and he did not want them. He was not concerned about his medications. He said, if we can't figure something out. We're going to go back to Mexico. I called all around to try to find options for him, and finally got information on the Bay Area help desk to give me some information. But then I tried to reach him, and as you heard earlier, his landline was disconnected. I could not get in touch with him. I don't want to leave you with completely sad feelings here. So I will tell you that he ended up coming back to the clinic for something, and that's how I got in touch with him. And we were able to help facilitate getting temporary housing for him through a program, a charitable program that was based in the San Francisco Bay Area until he and his parents were able to get more long-term housing. But just the point of that story was really that he could have cared less at that moment about managing his seizure medications, even though he was still at risk of having seizures. It was so much more, and it was so much more important to him, and therefore to me, that we really took care of those social needs. So you can go on. So we've thought about a number of different things. What can you do in the clinic setting? I mean, you can screen, you can help navigate, you can collaborate. Sometimes there becomes a decision where, do you want to refer out for services for their social needs? Do you want to provide a direct service? It's not necessarily clear what makes sense. Different organizations and different clinics have different resources and capacity to handle different things. So we've been thinking about what are the things that we can encourage institutions like the University of California, San Francisco, and their affiliated clinics, the Veteran Affairs Administration, the county clinics that we have. And so some options, and this is just things that are very, very US based on the next slide, that are useful, are we have a number of different services that we've been able to do. We're continuing to build and curate this list of organizational supports that can actually help. So we've got a really fantastic program at my hospital now, the San Francisco General Hospital, which is a medical legal partnership, which is co-sponsored by the National Center for Medical Legal Partnerships, where they bring lawyers and advocates who provide low cost or free legal services for patients. And so they bring that into community health centers, into health center practice settings, and provide those legal services for patients really at or near that point of care. And that's been a fascinating program to watch bloom. And so there are a number of other things like that we're beginning to see that are these hybrid models of medical social care, medical legal care. So with that, I'm going to stop, and I'm happy to answer more in the question and answer section later, but thank you so much. I'll turn it over to Nikki.
Thank you, Wanda. Gosh, I'd love to have more time to hear more about your research there, which was really, really interesting. And there's a lot of takeouts, but certainly the ones that stuck out for me were the cost of burnout in the sector, and that we think we're good at prevention and healthcare, but preventing burnout of our own clinicians is something I don't think we're so good at.
Yeah.
That the risk of burnout is much more pronounced in vulnerable populations, and that was certainly a takeout as well. I was really interested in the organisational 10 steps that we could take to try and prevent burnout. And as a CEO who employs lots of clinicians, that's something that I could use on a practical level. And and it's so important. Every day I'm having conversations with our clinicians here about how to manage stress and burnout. And I think it's really helpful to understand that one of the key things is the capacity, or their perceived capacity, to actually address some of this stuff. So that was great. It was really, really useful and interesting, and keen to learn more about it. I think we're going to do more polls and Q&As at the end of the session. So I will, I'm going to cut over now to Andrew Miller, who will further discussion around social determinants of health and move more into the area of team-based care and share sort of some of his experiences there. So thank you, Wanda, and hello, Andrew.
Hi, I hope you can hear me all right. I haven't checked this mic. You can hear all right?
Yes, great.
Perfect.
Yeah.
Wanda's talk was very interesting. I got to see that a few weeks ago, and it actually has had a profound effect on my thinking about what I'm about to say. The challenges, the resource challenges that they face in the US are no different in New Zealand, and the populations of where I live in Northland, we've got lots of JRs living in Northland who share exactly the same difficulty in getting care that's wrapped around what matters to them. I'm just going to talk today a little bit about what we've been trying to do in Northland to support patient-centered interdisciplinary care. And I am generally an optimist, and I might sound grumpy throughout this talk, but this has been incredibly difficult. This screen here is just a shot of the electronic tool we use in the northern region called Whanutahi, which is an electronic personalised care plan. So the about me a little bit there is wherever someone puts a story about themselves, which is probably one of the most important things we need to know about people, is just their story. And I think we're more and more driven by in our jobs by being demands of measuring things, ticking boxes, making sure we do all the things that's evidence-based, following pathways. And it's a frustration, because as we do this, we're spending less and less time listening to the about me and what matters to me that patients are trying to tell us. And that's actually is where the most gains will be made, is particularly for the JRs of the world, those at highest need. Someone wiser than me recently said at a meeting, he said, in my job as a GP, it's the 10% of the things I'm not able to do that would make 90% of the difference. And it's the about me and the what matters to me for our most vulnerable populations that needs to be sorted before we can dive into evidence-based medicine. So about me, personally about me, some of you guys would know that I got quite unwell a few years back. I was off work for 16 months, and I became about as knee-deep as you possibly could as a patient. I had 16 specialists look after me. I had about the same number of nurses, 8 allied health professionals. I had no care plan. I had absolutely no idea who was doing what when. No one asked anything about me. No one asked what mattered to me. I had no access to my records. And so it tends to sharpen your focus somewhat when you're on the receiving end of the health system. It's certainly been a driver for me to get on and try and make things better up here in Northland. So just to dovetail onto what Wanda was saying, what resources would you actually need if you were going to do a good shared care? And this has been stolen off my friend Janine Bycroft, who pointed out there's a few things that obviously are useful. You need someone to coordinate, a key person that you can go to and talk to about what you need. You need some sort of care plan so we're all on the same page. That should be, in my view, electronic. It should be accessible from any device, from anywhere, and anyone in your care team, including the patient, should be able to get in and out of that. Care plans have to be proactive, so we're actually planning ahead of what people want. They need to be a flexible funding. So if we hear things that people need, then if there's funding to make that happen, that should be easy to get hold of. And also at the provider end, if someone needs more care than someone else, they need to be resourced better to make sure that you apply funding to those that need it most. At the moment, it seems like everybody inside any program we've got gets pretty much the same resource financially, which just doesn't work. The other thing we also need, I think, is the people outside of the practice who can act as navigators, peer support, health coaching, all the people in the community. And I guess using one term, they're the people that are going to douse the burnout that we've got to a large degree. So a bit cheekily, I've said, what matters to you matters to us. And actually, sometimes it should matter to us. But because of some of these resource challenges we've got, things at times have come to a bit of a grinding halt. I'm just going to run through then some of the things up in Northland that I can see as some of the resource challenges. So looking at sort of patient-centered versus provider burnout issues, the collaborative who've organised this meeting today, just as a background, see proactive planned care as one of the key elements of our healthcare homes. And we're looking at this in much more detail in terms of a national lead on trying to get some of the stuff that's disabling good proactive patient-centered care planning more over the line. Up in Northland, we've got a bunch of things in our practice area we're doing. We're looking at registers of our patients, trying to get MDTs running, getting these care plans running, looking how we work with nurses and getting other staff members involved in care. We have equity of the centre, everything we do in Northland. The outcomes for Māori in Northland are shameful, to say the least, and we have to take that as a driver to try and make things right. And this business about patient-centered care planning is pretty much international. So this comes out of this statement comes out of National Voices in the UK, but patients are saying, I can plan my care with people who understand me and my carer, allow me to control and bring together services to achieve the outcomes important to me. That's pretty much non-negotiable and a bit of a no-brainer. But sometimes the patient voice is left out of our conversations about how we should be delivering care. Great Don Berwick would say there needs to be a radical redesign to move from a focus of quality improvement, that's the measurements I'm talking about, to much more courageous pursuit of well-being. We talk about healthcare, and I think quite often that means things like giving people the right treatment or making sure they have the right procedures, or it's medicine. It's not to do with healthcare. I mean, health's about well-being and care is about caring. And quite often if we don't actually go down a slightly different track with what we're doing, we're not going to get the results we need. And none of us are smart as all of us. So us as providers need to wrap around those in the community, and particularly our patients, to have them engaged in a true partnership with us to make sure that we're doing what they want of us. I came at this a little bit cynically a while back, thinking, really, I can't get this care planning working in Northland, what's going on? And I sort of come up with a slide here, which I was thinking, maybe it's the doctors just don't care. And then looking at what Wando's discussed, it's just because when you don't have the resources, you just don't want to ask the questions of people. If you do that, you're really setting yourself up to feel like a failure, and you're actually disengaging patients who've told you what they want. You're not delivering, and in doing so, disenfranchise them to a degree. In my view, it's a little bit like taking, for instance, a cervical smear and not sending it to the lab. It's almost borders on the unethical, doing things, asking questions and then not delivering. It's dangerous for both providers and for patients, and certainly Wando's shown that in the US that it burns people out. You guys probably have seen this. This is pretty much comes around New Zealand. It's the current care planning process with enrolled patients and stratifying them and getting pathways running and putting them into plans and then trying to wrap people around. I object straight away to number 2. Patients aren't risks, we risk stratify. I mean, really, patients are opportunities to improve their care. And I think, unfortunately, in my view, this actually completely misses the boat. We've got to get targets, do this number of care plans, get this number of people on board, find the ones that are most risk. It actually misses the mark. In my view, this is what we should really be doing as step 1, actually finding out from the people we're serving where they are in a continuum of being activated. Who needs the support? How do you tailor it to get them across the line? And how will that improve people's care? There's lots of ways of doing it. This is a patient activation measure from the UK. But many of the JRs of the world that Wando are talking about, and many people that I deal with sit at level 1. They're actually overwhelmed and disengaged because of social determinants. We will call them non-compliant. We'll say you're non-adherent. But unless you resolve some of the social determinants they're telling you about in their story, there is no way they can move forward and become more likely to be able to self-manage. I recently had a guy, I've known him for 20 years, he was like down in the dumps all that time, and I asked him about it in a care planning process, what mattered to him or his goals was. And unbeknownst to me, after 20 years, he said, I need to deal with my gambling addiction. I pointed him in the right direction. Next time I saw him, I asked him about that. He said he was much more in control, then asked me, what was it I was saying about his diabetes? So without actually asking the questions to the people in level 1 or level 2, we're never going to move people through anywhere. We're always going to make them feel worse than they currently are. And that happens. You get people come in who we talk to about their sugar control and their weight and all sorts of things. And really, it doesn't help them at all. It actually makes them probably feel worse about themselves because we're not actually pointing them in the right direction. That's just one advantage of patient activation. These tools reside all over the place. This one's called an outcome star. They use this in Auckland. This is actually one for homeless patients, actually. But it puts people in a continuum of where they sit, and knowing where they sit is much easier than to tailor what you're trying to talk to them about in a way that's likely to make them feel more empowered. And what these things mean, so if you look at actually patient activation, it's a better predictor of health outcomes than socio-economic determinants like ethnicity and age. You actually get patient activation right, people are going to adopt much better lifestyles. They'll probably come in and do their screening and checkups more often. Their clinical indicators often improve, and they actually take a capable and fulfilling role in their own care. I'm not going to dwell on this, but really, if you look at what patient activation does to health outcomes, The yellow, the blue on left is level 1, and the yellow is level 4. Those with highest activation actually have to come into the doctor less often. They got better outcome measures. They get admitted to hospital less often, and they actually get readmitted less often. This is really powerful stuff. The other thing is they're actually more satisfied. When you get them moving across that spectrum of care, they feel much more satisfied about how the system's looking at them and helping them. So that if you risk stratify, generally in New Zealand we'll say, oh, this person's a risk, you know, they're a danger to the health system, they need to really sort them out. And quite often if you haven't got their activation right and their motivation right, you could say, oh, they're non-compliant, they're not adherent, they're actually a bit of a deadbeat actually, they don't seem to be doing what I'm telling them to do. And really I think unless we get patient activation right, we're going to get into trouble. So this is probably, probably what we should have actually said, which is I'm sorry, and I'm going to try and do my job a little bit better. So looking actually at funding and investment, because we're talking about resource, and again in the northern region, I don't think this will be any different other parts of the world. There's a whole lot of documentation about shared care and interactive and interdisciplinary care being important. This is the regional document. This is the foundation document for how the northern region in New Zealand is going to invest money in the next 10 years. And they talk about a shifting of, you know, out of the hospital to interactive network models, patient activation. Beautiful, looks absolutely perfect. When I attended a meeting where they presented this, I asked a little bit about shared care. I asked about the resources to get navigators and the links in both in primary and secondary working, and I got actually told to be quiet, to tell the truth. It was, we're not really particularly interested in that, but we can talk to you about how to build a hospital, and that's what they're currently doing. They're focusing entirely on building hospitals. No interest in what they actually put down in black and white here, which is quite disappointing. So what's not funded in that plan? Care coordination workforce, interoperability of our systems, flexible funding for patients, the navigators. And I said they know how to build hospitals. They told us what that was going to cost. And the IT. So I think this is quite important. I think we talk a lot about shared care planning, but if you've got IT limitations in what you're trying to do, patients can't get in and out of their system. This is a really big problem for burnout. I mean, in my view at the moment, our current shared care systems are actually a disabler to care. They're not, there's no enablement going on. In fact, there's such a limitation in terms of how they function that the providers and patients are finding them so frustrating that you're almost making this something that won't work. We use a whānau tool up in Northland. So I'm going to zip through some of the things that how this tool works, just for those that don't know. Every time I try and get into this tool to look at a care plan, I have to log it in every single time. There's no single sign-on. So that as a provider instantly puts up a barrier. The previous slide is every day as I come out of the practice, someone has to do a manual update of the system. So there's no way of automating it. In fact, that's not true. It's just that the vendors don't want to cooperate with each other to allow this to occur, which again is a minimal resource, but a maximum problem for those at the coalface who are burning out when we have to waste time dealing with systems that don't work. We've done a little bit of work. This is a little bit hard to see, but on our patient dashboard, which is the a little indicator of what the patient status is, the very bottom green button would say that this person has an active care plan, that one there, which is a recent improvement in our system. We've color coded it so you can see if they've got a plan, if they need a plan, if the plan needs updating. So this person is in red because they haven't got a care plan but need one because they've got some conditions that would merit one. And on pressing that, we just open up the plan, so it's pretty easy to get at it. See, sorry, previous, I'm going too quick here. I'm just going to go now just into what we're actually trying to do up here in Northland. So we've got 106,000 patients up in Northland. All of them are inside the shared care system now. It means that every single patient in Northland could have potentially a care plan made by any provider that's got access to the system. We have a summary record of all their base information, which I'll show you shortly, sitting for anyone to view in terms of patient safety. So we've got all our GPs, all our practice nurses, all our community pharmacists, all our primary health providers with access to the system. We've rolled it out now to 220 users in the secondary service, but we're still having problems with it how these systems interoperate. And we're, by the end of the year, going to launch full patient access via a portal, so patients can make their own care plans, put in their own information, and do their own advanced care plans. This is just the hospital view. So that little button there, any patient they bring up in the secondary service, they just press that view button, and some summary information will arrive. Up in Northland, every month there's about 2,500 views of this summary information. So this is information that secondary clinicians really do want to see. So they get a view straight away of what medication someone's on, what diagnosis they've got, who's in their care team, and if there is a care plan, they can click it and open it. So straight off their front desktop, they can view it. If they actively want to take part of care planning in the secondary service, matter of clicking a little icon, they log in. This is a login page if they're not part of the care team. I guess it's a way of making sure that you don't breach privacy. They can go into the plans, they can open up the plans, and that's where we got to at the very start of my presentation. We are really struggling to get our secondary colleagues involved in care planning and actually actively take part in care planning because of burnout, I believe. They just see this as extra work, and if they're asked the what matters questions, they have exactly the same thing we have in primary care, that the things that they bump into, they've got no way of actually resolving. So I guess my goal, personal goal here, is that we're looking at how we can actually make some difference here. So that was that slide I showed you personally, but those are the things we're actually trying to make happen up in Northland. Oops, I've done it again. That's the no, guys. So these are things that we're actively working on, and so it's a bit of a busy slide. But as I said, we're trying to get a patient portal so people can get in and out of their care plans. We're in a conversation with the Healthcare Homes Collaborative and the Health Safety Quality Commission here in New Zealand to get some open standards for what goes into care plans, which means they can travel anywhere in the country. We are investigating what patient activation measures we should be using here up in Northland, because I think it's a critical enabler of making sure we get the conversations right with patients. We're organising multidisciplinary team meetings at the moment. We're looking also at shared medical appointments. This is all through our healthcare homes work. We also need to recognise that burnout's important, and we're having conversations with funders and IT developers and our staff. We have to recognise that we're setting them up to fail if we can't get some of these things I'm talking about resolved. The other thing we're doing in Northland, which is a huge change in our view, is we've set up a single primary care collaborative for the funding of all of primary care, both secondary and primary, that is going to run its planning out of the needs of communities and localities, which vary across Northland and both geography and local relationships. We intend to work backwards from what people tell us they need to the funding, not the other way around. We are going to be, from here on in, answerable to communities and not vice versa. And I guess too is that, I've been working for 2 years trying to get this stuff running, and it's quite wearying. I still will remain quite confident. But at some point, I think sometimes you have to admit defeat. If people aren't going to actually help us move in the right direction, I've probably got some other things I could be doing that aren't quite so trying, I would say. But I'm not yet given up, because I think what matters to you does matter to us. And maybe I'll end up looking at that guy coming out of the coal mine out into the sunshine. So thank you.
Thank you, Andrew, for that presentation. Yeah, it was. Again, it raises so many questions, and it would be good to have a lot more time to talk about so many aspects of it. But yeah, I guess I've got a couple of questions. A couple of questions that have come through, and I'm interested in your opinion on a couple of things. So I might just jump straight into that. I guess I'm curious about you talked about risk stratification, and I'm curious about your view on that approach, risk stratification versus need stratification, and what the difference is and what you think we should be looking at in this context.
I think the very first thing you do is I don't object to risk stratification. I object to the term. Patients aren't a risk. It generates an opportunity to work out a way of looking after them in a way they want us to look after them. We make assumptions all the time about what they may or may not want, and we actually need to step back and actually ask them what matters to them for a start. I think that what I'd like to see is that we spend more time finding out where they sit in terms of being able to deal with the things that we think are important. In a situation where they're overwhelmed and disengaged, the thought that they should somehow be more compliant or more adherent or do what we ask them is just asking for trouble. For ourselves, we'll feel unhappy. We'll make them feel more unhappy they're failing, and they already feel like things are hard. We're going to make it harder for them. And I think that if you risk stratify, the thought is at both ends. You've got people you're probably going to have to really work hard alongside. I think at the other end, you find people that are highly engaged, and we've got them in and we're not giving them everything that they want. We could probably find that a lot of people, not on the pointy end of risk stratifying, but actually the other end, could self-manage perfectly well if we gave them the resources that they want. But we tend to deliver care to everybody in a very similar manner, following very rigid guidelines and pathways, and that just doesn't, in my view, seem sensible or be as good a way of resourcing the system in our time as it could be.
Yeah. And in terms of the way you've approached the care planning there, and in the context of Wando's discussion, do you think having the care plans increases yours or other clinicians' perception of the capacity that's available to address these things? So I guess I'm asking if you think the care planning, the way you're doing it at the moment, is sort of making things better or worse for clinicians.
I think that every now and then that conversations like that guy that told me about his gambling addiction, and the moments that you hear that people tell you something that you can see as the barrier to them feeling well and feeling better about themselves. Every time that happens, you feel better about your day. I think that we need to be doing this, but we need to find a way of allowing us to ask those questions safely, with a way of resolving the answers when we hear them. So the Wanda has really made a clear point that the number one factor is we don't have the resources to deal with what we're hearing. We're greening to a degree with no treatment options, and that is hard on clinicians to do. Patients want to do this. Patients want to tell us these stories. Patients want to feel that we're listening carefully to what they have to say. And unless we do, we bump continually into this barrier where we're not feeling like we're actually quite getting it right for them. So I think that we would like to do it. I mean, Wanda also said that all those things make people less cynical. They make them feel more happier about their being altruistic and doing their job properly. But you set people up to feel worse if you can't give them the resources to resolve what they're hearing. Maybe Wanda would like to sort of jump in there, because I know it's really what you were saying, I believe.
Yeah, I think, I agree with everything you said, and thank you for that presentation. I agree with you in the sense that part of why it almost feels like it is the responsibility of the system that is enabling or requiring, or the place that is providing care, to also find ways and resources to meet those needs of patients, is that patients place a high amount of trust. And there's some other studies that we've done that have looked at this, a high amount of trust in that relationship with their GP and their primary care practice team. And essentially they don't necessarily understand why we would be divorced from all the other needs that they have. So when they come to your office and they're saying, I'm homeless, I was evicted, I have, these challenges, I have a gambling problem, as you mentioned, or whatever it might be, they expect that we're going to be able to help them. And sometimes it's quite surprising to them when we say, well, I can only take care of this or that, particularly for the GP, right? Because the notion of being kind of a wholesome provider for a patient and their family and their generations of family, it doesn't make a lot of sense to people that we can't be that. So I think that being able to, from the view of a patient, they're investing a lot of trust in us, in that relationship. They tell us things that they don't tell other people. I think it's happened to all of us. Patients tell you things, and no one else in their family knows it, and they really confide in us a lot. So being able to be positioned to meet them wherever they are, I think, is so important.
And I've got a few more questions here, which I'm going to carry on with, and there may be some polls that come up at some point as well that people want to answer, and we can have a look at the results of those. I know this question is for you. I was interested in your view around the electronic health records, and you talked a little bit about, I think you briefly mentioned that they may have contributed to clinician burnout in some way. I might have got that wrong, but you can tell me. I was just interested in your experience of the introduction of electronic records and electronic shared care plans, and the impact on your role as a physician, and how you think those have progressed in the States, good or bad or otherwise.
Sure. Yeah. No, you heard that right. I did throw that in there as one of those things that has been described as a very common cause of workplace stress for clinicians. So and it's fascinating to see what has happened over years. I remember being the head of a network of clinics many years ago. We were implementing our first electronic health record, and there was a very big mix of enthusiasm and great fear and panic. And people were holding on to their paper charts for dear life and saying, "No, this is the way we practice medicine." And then now seeing that it is almost an expectation. There's no resident that would finish a training program anywhere and go practice somewhere that didn't have an electronic health record. Like it is what it is, right? So that's what it is. But what has happened as a result of that is that you've really seen this kind of bifurcation in experience of practice. I mean, we don't yet have we don't have the perfect electronic health record at all. So regardless of what you're using, some are better than others, but none is really perfect. And so you've seen a lot of frustration from doctors all over, and there's no real age or gender or economic kind of predisposition to the frustration. Just, you can see it in all generations and all sorts of providers, just a frustration around what the EHR has done to the practice of medicine, and how, when you're thinking of charting and documenting an electronic health record, it is different than the way you think about extracting information from a patient. And so, I remember, I know it happens to me a lot when I'm trying to think of when patients are telling me a story, and I'll say, okay, so what can I do for you today? And they're saying, well, I went to my grandson's, graduation, and then I slipped and I fell. And then I'm trying to find in the record, where should I put all these things? Some of it is social history, some of it is medication, and it doesn't flow with the way that people talk and engage. So that's been a very big source of frustration. And so I don't know if we have a real solution to that, because they're not going away. I mean, we can't take them away. It's a matter of, can we get, I've been making a push. I published a paper a couple years ago in the Journal of the American Board of Family Medicine around getting more clinicians and people that understand clinical processes to actually start to influence the vendors of the electronic health records, so that we can build things that actually reflect the way we deliver care. So maybe that's one solution that we can offer.
I can't agree with you more. That dashboard, my front page of my system I showed you before had a dashboard on one side with red and yellow and green icons. I read something recently. It was actually about just that clutter. It's a bit like if you're in a cockpit of an airplane, you'd probably crash if you were trying to use an electronic health record. There's just too much going on. The expectation from this article I read was that if I tried to turn all those icons from orange or red to green on every patient that came in, I followed every pathway I was meant to do everything, measure their weight, their height, talk about smoking a lot. It would take me an additional 7.4 hours per day of getting my electronic health records sorted out. And while those things are there, they're red, and I'm being measured on those. My provider, my funders and various organisations are looking over my shoulder and telling me I'm not doing my job properly because I've got a whole lot of things on that dashboard that I haven't done, and it's driven by evidence-based medicine pathways. Meanwhile, I'm facing away from the patient. I'm looking at my screen. I'm trying to do stuff that makes no difference to them at all. I think to a degree they resented. I had a patient recently who said, "That was really lovely today that you sat and just talked to me without looking at your computer." And that's pretty horrible to hear. And I bet you many of us turn our backs regularly on our patients or stare at our screen while we'd be better talking to them than trying to get a whole lot of things done that actually make very little difference to the patient.
Thanks, Andrew. So I think we will run some polls now. There'll be several that'll pop up on your screen. There's a same question that we looked at the beginning, but we'll do these all together. So the first question there is, in your role as a clinician, so this is for all the people that are watching today, if you could answer these polls and we can get some views from you. In your role as a clinician, to what extent have you experienced burnout as a result of addressing social needs within your enrolled population? Question number 2 there is, in your opinion, do you believe there's capacity within New Zealand primary care sector for clinicians to address social determinants of health? Question number 3, shared care plans will improve patient care, but in your opinion, will they also improve the provider experience of the 4th quadruple aim? And the last question there is, what do you see as the biggest barrier to achieving good shared care in New Zealand? And there's just some things to choose from there. So there may be other things, but we've just given you 4 choices there in terms of what you think the biggest of these barriers are. So we will let you poll there for a minute or two, and while we do that, I'll just check that I've covered all the questions. And yeah, excuse me, I guess it sounds a little bit doom and gloom, I guess. So and I know it's not all doom and gloom, and you know there's lots of things we can be doing. So maybe Andrew, this question's for you, and then Wanda, I'll ask you the same question. Have you had some successes, and you know what sort of things could we do tomorrow or next week when we get up in the morning to make things easier to address social determinants without burning out our clinicians?
I think the thing that would be is at a big, broad and maybe national level, I think we're often blame the vendors for not making this easier for us, but I think it's actually our fault as both clinicians not demanding of the people that pay the bills to vendors to give the vendors a clear steer on what we want as actual coalface providers, what would make our job easier. And I think the time has come, and it's rapidly approaching, where we tell the vendors what we want clearly, and if they don't do what we want clearly, we don't pay them. For a start, we actually should be not letting them decide what a system looks like. We should decide alongside our patients. That's the other thing I believe, is that the sooner we give patients almost entire access to all the information, which is their information, the better. We need patients to be entirely engaged with what we know about them. Those that can look after themselves and self-manage will take that away and do what they can. Those that can't will help them guide their way through the system in a way. So I'm quite confident we've got patient portals arriving. We're going to do that with our shared care planning, that patients are actually much more interested than we are. They've got, this is their stuff. This matters to them way more than it matters to us. So I think I don't feel particularly negative about this. I feel quite positive that we can get this right. But we've just got to help people a bit. We've got to help the vendors work a bit better. We've got to help the patients work a bit better. And we, as providers, have to step up a wee bit and go, this isn't good enough.
Okay.
Yeah. I agree with Andrew. I think there are a lot of opportunities. I too feel optimistic, and certainly didn't want to paint a doom and gloom picture at all, because I think one thing that we've seen, and one thing that we've been doing at my health center, is the one key question, and asking every woman of childbearing age just that one question: Are you thinking of or planning to conceive within the next year? And we've found, and you've seen it all over the world, that when that happens, just the fact that you ask starts to make people think about what do they need to, for preconception, counseling, or what kind of family planning will they require. And I think the same thing is happening, although we haven't, made it as consistent around social needs. When you ask patients about what are the other things that you are struggling with, and what are the other things that I could be helpful for, it gives them so much confidence in your ability to care for them, so sometimes just even being able to ask. And so trying to think through, what are the questions that we could ask that can maybe uncover some of the challenges that our patients are having. And then also just it gives you an opportunity to start figuring out what are the networks that we need. So for us in San Francisco, I'm not sure how many people have been to San Francisco, but we struggle with a very severe homeless problem. So I spent the earlier part of my career on the East Coast, came out to San Francisco and was completely overwhelmed by the homelessness here. And one of the things that I realized is that you've got to ask about housing. You can't just assume that a patient that walks into your office has stable housing. And now housing programs and housing authorities are really part of our larger circle of care. So I think once you start to ask what people are struggling with, you start to figure out what are the resources that they need, and you can start to figure out how to provide those or refer to the people that do it well.
And I guess identifying the key networks that you need, that's quite an important thing, I would imagine, for communities, because it's easy to be overwhelmed and think you need a large network of, education and housing and, income support, et cetera, et cetera. Is it worth just looking at one or two key networks and starting there? Is that the approach you would take with the communities?
Yeah, it could be overwhelming if you feel responsible for every, social, environmental dimension of someone's life. But I think starting to understand what are the things your patients are struggling with. If it's a place where, where I trained, there were high levels of substance abuse, and, starting with prescription drugs, moving on to under, offline, under the market type of drugs. But there might be different needs in different places. So trying to figure out what are the, maybe the 2 or 3 that we really need to make sure that we have resources for, and a security blanket for, and then you can, add on as you start to build that. I think that's probably the way to go about it, so it's not overwhelming.
Good. So I think we've got some poll results now. We'll have a look at what people watching today thought. I'm not sure if you can see it on your screen. I'll read it out, but hopefully you can see it as well. The first question: in your role as a clinician, to what extent have you experienced burnout as a result of addressing social needs within your enrolled population? 20%, 0 said extremely high. So this is to what extent. Extremely high, 0. That's good. High, 20%, moderate, 50%, and low, 30%. The second question was, in your opinion, do you believe there's capacity within the New Zealand primary care sector for clinicians to address social determinants of health? There's a lot of moderate voters in our audience. So 20% said definitely, and 60% said maybe, and 20% said not at all. It's an interesting result. And I guess, that 20% signals to me that if 20% of clinicians feel that there's no capacity, there's a big burnout risk there based on what we saw around the research. Number 3, shared care plans will improve patient care, but in your opinion, will they also improve the provider experience? The fourth area of the quadruple aim. 30% said definitely, 40% said maybe, and 30% said not at all. And then the fourth question: what do you see the biggest barrier to achieving good shared care in New Zealand? What do you see as the biggest barrier of these choices in terms of achieving good shared care in New Zealand? 10% said the IT tools were the biggest barrier. 30% said lack of funding / an investment was the biggest barrier, and 60% said lack of resources such as health navigators, social workers, etc. was the biggest barrier. And nobody thought the lack of national standards was the biggest barrier of those. Yeah, well, those are really interesting results, I think. There was just one more thing that I wanted to ask both of you before I think we'll wrap up and wrap up what's been a really interesting discussion. I'm quite interested, and it relates to the fourth poll there, and what you think the role of non-registered health professionals is in addressing social determinants of health inside the practice. So I guess the healthcare home model encourages alternative roles or new roles, extended care team roles such as healthcare assistants and health coaches and health navigators, etc. Are there any particularly important non-registered roles that you think practices should look at employing or having within the team that are critical to this issue?
I think that we're underestimating the resource of volunteers and patients themselves to help each other, and they're a free resource, they're a motivated resource, they're by far the most often useful people to talk to, and if you've got a health issue, is to talk to someone with a similar health issue as you and ask them how they're getting on with it. I can give you a direct personal experience of that the people that gave me the most help when I was recovering or needing answers for my own health were other patients. I went on to support group sites and websites and actually talked to other people who rapidly answered, and I believe those people because they knew what they were talking about. They knew exactly what it was like, and we don't use that resource, I don't think, anywhere near as much as we should. The other thing I think is that we've got a whole lot of community people seeing, or NGO, non-governmental organisations and caregivers and meeting patients and not having a link back to us as GPs to tell us what they've seen and what they're concerned about. I'd imagine the power of information of home support workers around, particularly around the elderly, that could tell me stuff that really matters. I say they're not taking their medication, their fridge has got no food in it, they're not, they're not coping, and they've got no link back to me at all. And again, there are a huge workforce that's not linked, and yet they're the caregivers. They're the people that actually care for vulnerable populations, and they're not being able to get back to me with that amazing knowledge and resource. And I think it would work both ways, that if they were to tell me I could help them out, then it's likely we'll form a relationship, that we're all part of the same team. We're all caring, actually, in the true sense of the word, not just delivering medicine or delivering medications. We're actually caring for someone, and that's sometimes, I think, missing. And when we talk about healthcare, is actual true, just being nice to each other. Dare I say?
Thanks, Andrew. Wanda, do you have any comment on that?
Yeah, I don't know if I could say it any better than Andrew did. I think that was very, very well said. I mean, I absolutely think that the role of the non-clinician and other, healthcare professionals and paraprofessionals is super important, and it requires a team to be able to access some of the information or the needs and the emotions of patients that we may not be able to get in these very short visits where they're coming to us. And agree with you, if you can close that loop with people that have access and a window into people's lives beyond the healthcare encounter, it's enormously valuable. And so, I didn't mean to imply that all of this has to be the primary care provider doing it, but if there are people that are, we have these community health workers and other patient navigators that are able to really see patients where they are and understand so many things that Andrew mentioned, what is their home situation like, what are their other struggles like, that they can now feed back to us. One of the challenges that we have is those folks are often not connected to the same system that we're in. So I think in your shared care plan, I think that is an attempt to try to get multiple voices to be able to weigh in, but sometimes that information is extracted, but it's not relayed back to the person that's providing care. So that's really just kind of bridging that gap is one of our challenges, but I think it's important to have those roles.
Great, thank you. Is there anything else either of you would like to say, discuss, comment before we wrap up that you'd like to share with everybody today? Great. Well, I would just like to say thank you to you both, and it's been a really, really interesting session. We're really grateful to have your input, and we can just see that you're so dedicated to this area and you've got so much to share. So thank you on behalf of everybody listening, and thank you on behalf of the Healthcare Home Collaborative. I'd also like to thank the Healthcare Home Collaborative for bringing this webinar to everybody. I think these webinars are a great way to really generate some discussion and have a bit of a thinking group. So it's great. Thank you, Healthcare Home Collaborative.
Thank you, Nikki.
So I'm going to just pop up the screen to show you where you can find this webinar. If you want to, this webinar has been recorded and you can find it here after today.
Nikki, thank you so much. Thank you, and thank you to the collaborative as well.
Thank you, Wando, and thanks, Andrew. We'll sign off now. We'll see you again.
Okay, thanks. See ya.
Thanks everyone listening, joining us. Bye.